Hello, everyone. I'm Suraksha, health correspondent with Deccan Herald. This is Dear Sparks on navigating India's second wave of COVID-19 and the lessons to be learned from it. India so far has seen more than 2 crore COVID-19 cases, with more than 2 lakh succumbing to the infection. This is, of course, a gross underestimate of cases, as there are several reports saying that India is undercounting both its deaths and cases. These numbers officially are only second to the United States in the world, that has seen more than 3.3 crore cases and 5.9 lakh deaths. The principal scientific advisor to the Indian government has already said that a third wave is inevitable in the country, though the timescale may be hard to predict. The apex court of the country has already told the central government to prepare for a third wave, saying children might also be infected in this wave. But to start with preparations for the second wave, we need to navigate the current wave. We have an already strained health infrastructure and overworked health workers. To help us understand when the second wave will peak and what's the best way we can face and overcome this peak, we have an eminent panel of experts here with us today at DH Sparks. First, Dr. Ramanan Lakshminarayan. He is an epidemiologist and head for Center for Disease Dynamics, Economics and Policy. We also have Professor Gautam Menon, Professor of Physics and Biology at Ashoka University, Haryana. He has worked on several COVID models. We also have eminent virologist Dr. V. Ravi. He is the nodal officer for genetic confirmation of SARS-CoV-2 here in Karnataka. And last but not the least, we have Dr. Vinita Bal, immunologist and faculty, Indian Institute of Science, Education and Research from Pune. She's also a former scientist with National Institute of Immunology. Many thanks for joining us, gentlemen. Dr. Bal, thank you for joining us. Professor Menon, if I may ask you first, when will the second wave peak in India, and what are the potential daily numbers that we are looking at?
That's the hardest question to answer, Suraksha, in any reasonable way. We believed, many models were suggesting that the peak would happen roughly across the middle of May. Now we're already getting into the first week of May, and the numbers are showing no sign of really slowing down. There are around 410,000 new cases every day. So we might have to push that a little more. It's very hard to predict at this moment, to say anything really from models, precisely because of the huge uncertainty surrounding the numbers. We know there are many people who are not getting tested, who ought to be tested, who would not, under normal circumstances, had tests been available, would have been tested. We know that deaths are not being recorded accurately across large parts of the country, even in states which normally would be expected to have better recording systems, better health systems. So all of this uncertainty really adds up. We don't know whether, even if we see a peak, it will really be a spurious peak because we're just not testing enough. And we don't know whether there is an underlying peak really in the data of cases that might come later. So right now, what we're observing, what we're not measuring accurately, together with what we're seeing, is really confusing the sort of things that models might be able to contribute to. So I can't give you an exact, sort of even a really good indicative number. I would have thought the 15th of May to the 30th of May would have been some reasonable space in which one might see a downturn. I would still, for the time being, hold to that, but that picture is now very much more clouded by this uncertainty regarding just the numbers.
So will it be right to say that we might see around 500,000 to 600,000 cases per day come mid-May?
Some of the models that we were running suggested exactly that range of 500,000 to 600,000. But of course, now the problem is that you're running out of tests. So you would not be able to even test if you were to get to that number. So automatically there is some slowing down because you're not testing enough. So that's the question, as I said, what are the real numbers that underlie the numbers that are official government numbers being put out on a day-to-day basis? In a situation where testing is very constrained, what indication do you have that these are the right numbers that you should be looking at and putting into models in order to be able to predict anything? So right now, it looks as though there may be a little bit of slowing down. We've been around the 410,000, 400,000, etc. for a few days. So it's not sort of going up as dramatically as one might have thought, but one should not read very much into it unless you see any sort of sustained behavior over something like at least a week to 2 weeks. Only then can you be sure of what's actually happening.
Dr. Ramadan, if I may ask you at this point, a problem with estimating the timeline of the peak in India has been that it has decreasing test figures. We've been testing anywhere between 15 lakh and 19 lakh COVID samples every day. Is it enough with the rising positivity rate? How much should India ideally be testing at this moment?
So let me start by saying first, thanks for having me here. And second, let me build on Gautam's response and maybe see if we can phrase this question slightly differently, including the first one. I know the media is very interested in when the peak will happen. Frankly, it's an irrelevant question. It is a problem for the country as long as the number of cases are above the healthcare capacity of the country. That is the question to be asking, not the peak. The peak is, first of all, we're talking about bogus numbers through and through. We're talking about numbers that, are undercounted by a huge margin. The first round, the government's own ICMR's seroprevalence survey showed that we were undercounting true infections by a factor of 30, 26 to 32, 30. That is a paper in the Lancet. So let us always make sure that when we say cases, we always say reported cases. And when we say deaths, it's always reported deaths. Our own estimates are that deaths are probably underreported by a factor of 6 to 8, which means that we're probably having about 25,000 deaths a day, at least sometimes. And so all of this continues as long as cases are above system capacity. And so that duration, I think, is going to last about 2-3 months across the country, and that's really the most concern. It doesn't matter if you're 500,000 above capacity or 5 million above capacity. Your mortality rate immediately goes up because the system is not able to take care of it. Now, the testing, I think, is so abysmal that it is not even really worth commenting on at this point in time. We've not really ramped up tests this year at all. Positivity rates, according to WHO, should be 5-10% at most, and hopefully less. So we need to expand our testing at least by 2x. And today it's impossible to get a test. I paid for a test a week ago. The diagnostic company didn't even send anyone out, let alone acknowledge anything. They just took the money and that's it. So it's such a chaotic mess out there that I think we should stop pretending we're living in some sort of organized world here as far as all of these go. And I think the true toll of COVID will only be told maybe months or years in the future when we have some estimate of excess mortality or from other measures. But for now, I think we should drop an obsession with this peak. The peak is one point, but the duration of the epidemic as its completely overwhelming capacity, particularly in rural India, is really the main concern.
So you're saying we should increase testing by 2x. So let's say we're testing about 20 lakh COVID samples now. We should be ideally testing 40 lakh samples at least.
I think you should be testing probably 3x because, the 2x is, remember, even our original testing was not really getting us to a place where we had a reasonable number. So if you want to match what a global standard should be, it should be 3x. But it's impossible. I mean, we just don't have this capacity has not been put in place, and it's not going to happen now.
Right. Dr. Bal, the Union Health Ministry and the Center for Disease Control recently admitted that the B1617 variant, or as the media has dubbed it, the double mutant variant, is a variant of concern and might be driving the surge in some states, including in Maharashtra, from where you're speaking to us from. Do you agree with this assessment?
If I have to talk as a scientist, I would say the data are far from adequate. But if I'm talking in my capacity as, say, a clinician who normally look for associations, then I think there are enough data to say that one major reason why the cases are going up in Maharashtra is B1617. That for sure. But beyond that, there are many other reasons that we need to take into account rather than blaming everything only on the virus. We ourselves, we as in community, we who let down our guard are also responsible for it. And I'm also equally blaming the leaders, either the religious leaders or political leaders. I should not say or, they're falling, both categories are included in this. They were responsible for showing that wearing masks in the public places is not necessary. So if this is what the leaders tell us, then the followers would follow. And that is what has been happening. And I have been saying this for the past 2-3 weeks at least, that I hope nobody from Kumbh Mela comes back and is around me, because Kumbh Mela was one massive scale boiling pot for the COVID spread. And that is something that is equally important, not just the virus. And of course, we will be talking, I'm sure, eventually about the infrastructure, which Dr. Ramanan also mentioned, that it is far from adequate. But yes, multiple factors are contributing to increase.
So as a scientist, you say there's insufficient data to at least now say that B1617 is driving the surge.
Because there are people who, like Dr. Ramanan, who will probably be able to tell you exact numbers, and I'm no good about this, that should be a certain percentage of cases which need to be sequenced so that there is reliability of the data. So, but the denominator, if you see, even when we are talking about, say, 5,000 cases from Maharashtra or say 5,000 from Bengal, it's like a drop in an ocean. So in that sense, I'm saying that yes, there is association, but cause and effect relationships are very hard to say. And that is why I made distinction between what a scientist should say and what a clinician should say.
All right. Dr. Ravi, according to INSACOG data, 17 states have this B1617 variant, most predominantly Maharashtra, West Bengal, Delhi, Gujarat. Karnataka has about 62 confirmed cases. If there are more, you will be knowing about it. The Health Ministry has now advised that the states should strengthen public health response in these regions where this variant has been noted. So how does this translate on the ground in Karnataka that sees nearly 50,000 cases every day? Dr. Ravi?
Ravi, are you mute?
You're muted.
Thank you, Suraksha, for having me. And right now, in the middle of this surge, I must say that it is one of the weak links, is the public health response. Because the entire workforce on the ground is busy doing many things. Remember, the same workforce is drawn into tracking, tracing, testing. The same workforce is also asked to vaccinate, ramp up vaccination. Last time around, we had help from Revenue Department, Home Department, Education Department. Now everybody is not available because they were busy with their own activities. So having said this limitation, the government of Karnataka is now looking at least in cases where variants have been reported, to increase contact tracing, because as Vinita said, it is very important on the ground. I'm sure Gautam and Ramanan will agree. There are two ways in proving a variant as a variant of concern. One is field data and the other is lab data. The field data, you have to have very good contact tracing, and then you have to then be able to reliably calculate the R0 between a variant of interest and a variant that is not of interest. And if you show that it is much higher, then you can say, okay, more number of people are getting infected with this variant. We, of course, also need cell culture data, which I think is being right now gathered. But this is going to remain a challenge, is what I will tell you, to say whether 617 or any of those are really responsible for the surge.
Right. We know that we have insufficient data. My question is, should we be doing something different in terms of a public health response for this, double mutant variant patients than we are already doing for COVID patients in terms of isolation?
Whatever we have to do to do properly, that's more than enough to get the information. It's because it's a mutant, the public health response does not alter. As Vinita said, variant is one of the several constituents that was responsible for this surge. I would put it low down in the list. Human behavior, I think, was abysmal during this time. It's not about blaming somebody. I think collectively all of us let this happen. And definitely people who can make opinions and who have an influence on the way others behave did not behave responsibly. That much definitely I will say. I will go with Vinita on that.
Right. Professor Menon, I wanted to ask you, do you advocate random testing? At present, we're only testing symptomatic people and primary contacts of COVID patients. You had said that every day, perhaps 8 million to 10 million people might be going undetected in India. So should we be testing asymptomatic carriers and interstate travelers, one which ICMR said they don't have to be tested? So will that up our testing rates and perhaps reduce the undetected in the population?
Right now, I think the problem really is capacity, lack of tests. Where will you put people who you test if you've detected they're positive? I mean, there's an advantage to doing that in the sense that you know how much it's spread in the community. That's at least something that we don't know in many cases. As you said, you're testing only people who come to hospitals, they close contacts, if at all, if they report together with the patients. But you don't know what's actually happening among this vast number of people who don't turn up in hospital and who potentially are asymptomatic carriers. It would help to have those numbers to understand what is happening, but it's not clear exactly as Dr. Ravi said that you should change anything at this point. And right now the problem is you don't have enough tests. There's been a good move, I think, from the ICMR to expand testing to include the rapid antigen tests, because then they're point of care tests. You can have many more of them. You can have drive-in situations where you can come in. People who just think that they need to be tested can actually report and get tested very fast and get a result fast. Maybe not an ultimately accurate result, but nevertheless something. That's one way of just ramping up by large numbers the amount of testing. They're cheaper than the PCR test, so there's also some economic advantage in there. I think that's the way to go.
So would you advocate random testing is my question?
Yes. I mean, but I would think that we first of all need to sort out so that someone who thinks that they have COVID-19 and don't want to infect anyone else can be tested. Right now, we're not even there. As Ramanan said, if you have a 6-day wait and the person still hasn't come to test you, that's a very bad situation to be in. So overall, we should ramp up testing in whichever way, including random testing.
Dr. Ramanan, people have now had a taste of what Kumbh Melas, religious gatherings, and election rallies can result in. Our country's economy is ravaged. We cannot have another full-scale lockdown, at least the kind that we saw last year. So how do we contain the spread, especially when a third wave is expected? And are things like night curfews and weekend curfews even effective?
Last year, you have to realize the lockdown was put in place with 500 cases because if you have only 500 cases, no one is going to take you seriously that this is going to be a big epidemic or pandemic, because who listens to scientists, right? They all say, even scientists may disagree with other scientists, but anyone who knew that this was going to be a terrible situation. And that's why we blew the whistle, and it was followed at that point in time. You need such lockdowns at a time when cases are not high, because people will not self-protect, and therefore you need to force them to self-protect. Today in Delhi, if you opened up everything, nobody's going to go out in any case, because you're going to be in a hospital in a week, and there's no hospital beds anyway, so you won't actually be in a hospital in a week. So people are able to self-protect if they are given information. And the worst thing that is happening is to not give people information. This obfuscation that has happened from day one of this pandemic has been the primary barrier. It is not even the Kumbh Mela per se. See, as Dr. Baul said, she said, I don't want to be next to someone at the Kumbh Mela. Those Kumbh Mela cases will only start now. The Kumbh Mela was not the start of the surge. The Kumbh Mela only communicated to people that it's okay to go out and do whatever you really want. So in the messaging part, it was terrible. But the impact of the Kumbh Mela, which I expect will be the largest super spreader event in the world, is only going to be felt starting now, which is why it's going to continue into the future. So lockdowns make sense when people don't observe cases and you're doing it as a public health response to get them to do something because they don't have the information or the knowledge to do so. Lockdowns in response to their cases already being out of control is really a waste, because today when I step out of my house, I go for a walk, just at 5:30 every day. Everybody is wearing a mask. Everybody is wearing a mask. And why? There's not even a single cop around. A year ago, you had to have a cop around to enforce this. So we have to understand why we're doing these things. We do it in situations where it makes sense, and it makes sense in situations because there are parts of the country, even today, which don't have a lockdown, where cases are starting to rise, but what they feel is, it is happening in Delhi, it's happening in Bombay, it's not happening here, so why should we really, go into a lockdown? Actually, those are the places that should go into a lockdown, because that's the way in which to head off a wave. Putting a lockdown in place once, the situation is out of control is really a waste of It's a waste of effort. What I mean, you asked about what can we do now. Honestly, there's nothing we can do now. You really cannot, as Rajiv Sadanand used to be, used to run RSBY before. He said at the beginning of the epidemic, you cannot build a system to respond to an epidemic in the middle of that crisis. You have to build it before. We had one chance before. We had a second chance in January, February, and we still don't have it. I doubt anything can be done at this point in time.
All right. Dr. Bal, we've repurposed many drugs for the treatment of COVID, and these experimental drugs are in short supply, be it remdesivir or convalescent plasma. Now, doctors are divided over its use. Most cite the WHO solidarity trials to conclude that they don't work. Yet, India is importing remdesivir vials. It has asked the 7 companies that manufacture remdesivir to ramp up production. We've also set up government helplines in order to facilitate the supply to patients. Because of the crisis that we're in, do you think there is an overemphasis on these experimental therapies?
Certainly there is. So I do seriously think, and I do agree with the solidarity and other trials which have been conducted. So repurposing of drugs was a very useful strategy to think of because we had jumped into a pandemic. So there was no scope to design and test new drugs. So repurposing was the only way out. So remdesivir, when it was tested initially, even in vitro, in tissue culture, so to say, it wasn't found to be phenomenally effective, but it was effective against the SARS-CoV-2 virus. So that is why it was considered at least for clinical trial. But if you look at the clinical trial data, what remdesivir does is it's an antiviral drug. So the viruses would be increasing in numbers in the first few weeks, not first few weeks, I should say first few days, and then the immune system will take over, and theoretically, in a otherwise healthy person, the virus number should drop down rapidly. At that point, within first 10 days also, there is something called cytokine storm that has a side effect that has been seen. So in my opinion, giving remdesivir, if at all, in the first 3, 4, 5 days is the best time slot to give it. What is currently happening is that when it looks like the case is going out of hand, case is going out of hand, these clutches we try to hold on to, that do find remdesivir, do find plasma therapy. And at that point, both are completely useless. So remdesivir has no use, but you have to remember something, that if the doctors cannot do anything, which seems to be the case in many of these instances, for most viral infections, this is the case in any case. So having some medication is what the patients want. Doctors need to be seen that they are doing something. And for that satisfaction, at least, sometimes the patients demand injections. Patients say, give me saline so that I will get better. So it's also that kind of medical practice which is prevalent in many parts of our country. So I do put remdesivir demand and the black marketing to an extent into that category. Let me come to the plasma therapy as the second point now. I think plasma therapy has its minor use for sure. But what you have to know again is that the neutralizing antibodies, which are the antibodies which will block entry of the virus into the cells of lung and nose and throat, so that those neutralizing antibodies are very critical, and their level in the convalescent plasma needs to be determined. So if, say, there is standardization that 100 units of neutralizing antibodies, this is an arbitrary number, but 100 units are required for the patient to feel better, then are we even testing for neutralizing antibodies from the convalescent plasma? No, we are not. We are simply taking it from one person essentially and transferring it to the other, because neutralizing antibody estimation is easy. It is not impossible, but it is also time consuming. So essentially, we are giving plasma therapy as a treatment, again, half the time for patients and patients' relative satisfaction. There is also ignorance among the people, the treating doctors, who think it will be useful. But again, you have to remember what in plasma therapy is useful: new antibodies. Antibodies are going to direct against virus. So when virus levels are going up, at that point, if you have adequate amount of plasma therapy given, then there is use. If it is in the quote unquote terminal stages, when there is really no other hope, at that time, unfortunately, patients' relative run around advertising for this plasma, this blood group, and so on and so forth. I think both are overrated, and doctors should be aware that if we can do without both of them, I think the doctors and patients and the relatives would be better off. There will be no black marketing, and there will be less hassles even for the relatives.
Point taken, ma'am. Dr. Ravi, this B1617 variant was first noticed in September or October last year, but we are seeing the surge in most states that it's prevalent in only now. So do we have any theories on why it didn't take off then and it took off now?
See, the main reason why variants take over is not because inherently they are more infectious. I think you should remember several small super spreading events are the sparks. Many sparks light a fire. Yes, many of these variants, even the UK variant, was detected 3 months before it caused a problem in UK. The Maharashtra mutant 3 or 4 months before. What we have to remember is when we let our guard down and there are super spreading events that light up, that's when even a Wuhan parent virus would have caused the same thing. Of course, yes, these viruses are more infectious than the other ones, so they are causing more trouble. If not to this magnitude, if you had allowed the Wuhan virus to stay and removed all the others, you'd still have had a surge. The surge would have been like the last time. So I think one has to remember that even in future, avoiding super spreading events is very essential. In fact, I would go to the extent of saying, can we be bold as a nation and say, no election, not even for a housing society for 1 year, no religious functions, no any major election, whether it is local body polls, panchayat, or assembly, heavens won't fall. We can continue to govern the country, and none of these super spreading events drive economy. I'm still looking for some economists to convince me this is required for livelihoods. It is not required for livelihoods. I'll stop here.
Professor Menon, do we have any data currently on whether the vaccinated pool in the country, that is about 3 crore are fully vaccinated and 16 crore have received the first dose as per the COVID dashboard? Is this vaccinated pool having any effect on the rate of transmission in the country, in any part of the country?
Well, transmission is harder to be sure, but it's certainly, you can see from the mortality data that it has made a difference. There's a nice analysis on Karnataka, which shows that the fraction of over 60s contributing to the total deaths has actually been coming down since vaccination started in, I guess, March for that particular population. That's very impressive. That really shows the difference, and it shows that states should get their act together and vaccinate as many people as possible. The center should help them do so. Whether it reduces, it's believed that it reduces transmission. There is certainly evidence, mainly I think from outside India and not so much from inside India, that vaccination reduces transmissions considerably. And so, but for the Indian vaccines, I think it's fair to say that we don't know yet and what exactly that might be. Maybe Dr. Ravi or Dr. Bal will have a better idea of this.
Dr. Bal, Dr. Ravi, would you like to pitch in on this?
It is very, very difficult to collect data on reduction of transmission, especially in a situation that we are currently. Maybe if the vaccines were available end of November, we would have had a 2-3 month window where we could have clearly said, look, it has contributed to reducing transmission. In my own personal opinion, I think we're asking too much of SARS-CoV-2 vaccine, which we have not asked any other vaccine. Which vaccine gives you guarantee against infection? Please name one. Why are we asking so much from a SARS-CoV-2 vaccine? It's a wonderful vaccine. It's preventing severity of disease. It is preventing death. What more do we want from a vaccine? I'll leave that question hanging.
Right. Dr. Ramanan, do the current models in India or anywhere factor in the information that we have on reinfections? Should models be rewritten to factor in reinfections?
I don't model COVID anymore just because it's a waste of time. It was worth modeling last February to give a sense for how bad things would be. And to do models, you need two things. The primary driver of the model is, of course, data, and we have almost no data to really, parameterize in a serious way. The second is, or not for lack of data. There's a lot of data available. It's just not available to researchers beyond, so some states, and we do that. The second is that the primary driver of disease dynamics is really human behavior. So as the prevalence goes up, people protect themselves, and as people protect themselves, the virus comes down. So and this is a moving target. So many people asked last year, oh, but you said, things would get so bad. I said it would get so bad if there was no lockdown. If you have a lockdown, then everything changes. So I don't think, first of all, these models I think are used for a particular purpose, but in a public forum like this, people who don't understand them misunderstand them as well, because they're used for a particular purpose. And it's not, some kind of astrology where you're saying, listen, this is what is going to happen. And if you start using it like that, then, then it's a miscommunication of science. It makes sense to use models in stages where you have the data or you don't have data, and you know the characteristics and you know what to expect. Last year, if we'd had no lockdown, we would have seen exactly the situation that you're seeing right now. What you're seeing today is the situation that we averted through a lockdown last year. Now, again, hard to communicate beyond a point, and I think it's a fool's errand to really run models anymore and fine-tune it for secondary infections and variants. My group does not model in India anymore.
Professor Menon,
you can ask him.
Professor Menon, do you know of any models that have factored in reinfections?
As far as I know, all current models don't do that, partly because we don't know what is the contribution of reinfection. Is it 20%? Is it 50%? We have absolutely no idea. And I think there is some data coming out that suggests a number like 20%. It's hard to see why we would see such a steep rise as we've seen across multiple states if there wasn't some contribution of reinfections. But how long does immunity last? Who are the people who are getting infected? Is it a milder infection the second time they contract the virus? Do the variants have anything to do with it? All of this is completely open. I wanted to add to what Ramanan says. He's right. It is a fool's errand at this time, really, to model SARS-CoV-2, model COVID-19. A, because the data are very messy. B, because the hardest element in this is people's responses, exactly as he says. Nevertheless, I think there's still some sense to getting an overall feeling for where the numbers are going, because they feed into decisions that states have to make as to how much medicine to buy, how many beds to set up, etc. It's much more of these somewhat more micro level decisions rather than where is the peak, when is the peak, how broad is the peak. So we have to do the best that we can with whatever we have, precisely to help governments try and decide where that sweet spot lies, what they should be seeing in a week or 2 weeks or 3 weeks. And here we're helped a little bit by the fact that a lot of disease is really inertia. The cases that will go into hospital 2 weeks from now are the cases who have been infected today. So once you know the point that I wanted to make.
Can you repeat the last part? So we lost you in the middle.
Yeah, sorry. I thought I was lost at that point. So what I wanted to say is inertia is very important. That the cases that are infected today are those who will turn up in hospitals 10 days to 2 weeks from now. So in that sense, there is some continuity between what happens now and what happens 2 weeks from now. And to give an overall sense of that continuity, I think is an important thing where models can actually contribute.
So as per both of you, models, it is pointless to, run any models right now, but what should models exactly be doing now? Guiding policy, guiding purchases, allocation of oxygen. What exactly can models be used?
They can use for all of those, and that's what we did in the first phase. We did do all of that stuff. We said how much the bed capacity would be needed, how much you need to prepare. All of that was done. But the government has its own supermodel, which said that after February 15th, we don't have to worry about it. And that's what they went with. So, these are usually in an academic world, there is no agenda. The agenda is only to be able to inform through the best of science. But once it starts being seen through views of politics and trying to do PR through it, then there's no point doing this kind of modeling. So we did it last year because I think it is hard to communicate. It's hard to communicate the sheer ferocity of this virus in a country like India without doing that sort of a thing. And that sort of model is easiest to do because you have to remember this virus is in the history of going back of medicine. It's the first virus that is a completely novel virus, which is a respiratory pathogen that we know of. The last one was SARS, the first SARS in 2002. So it is actually a very easy disease to model because this is what you teach students. You have a completely susceptible population and you start from there and you model. When we do that stuff, again, the purpose of these models is to communicate something. Then you have a whole bunch of voices that will come up and say, oh, but Indians have immunity, we have BCG, we have heat, we have this, that, and the other, and therefore we don't have to worry about, these cases. So then you say, okay, listen, this is all that you can actually do. That's the stage at which models can actually be helpful and they can help you plan. But once the infections start taking off, there's no point because then there's a feedback loop that goes between behavior and these models constantly. And that feedback loop is very hard to parameterize. And in fact, it's impossible to predict. And usually epidemics come to an end sooner than when these models would predict, simply because people are responding with behavior, right? With such a vicious disease, like I said, nobody in Delhi would go out even if you remove the lockdown. That's what models will fail to predict, but it's hard to really know how much that will be.
Dr. Bal, on April 7th, nearly 3 months after India began its vaccination program, the specimen referral form was amended to include questions on whether the person being tested had received the COVID-19 vaccine. If so, then which one? And the dates on which the first and the second doses had been received. Now, this means that tests conducted for 81 days prior to April 7th did not contain this information. Now, the vaccine does not protect the individual against infection. We know that. It only reduces the severity of the disease. But yet the Indian government came out and said that there are very few infections post-COVID-19 vaccination. So is there enough evidence to conclude that yet? Also, we do not know what level of protection antibodies from a prior infection give us versus what vaccination gives us.
So I don't think there are data, full stop. I mean, all of us have been talking about it, that we lack data. We don't have rigor or intention to collect data systematically. The form that you are talking about, I have had my 2 shots. Nobody asked me about it at all. And my second shot was certainly after whatever 10th or 15th of April that you mentioned. So nobody's implementing that. There are multiple reasons, as Ravi was saying. Everybody is so stretched because we as government refuse to employ people properly in adequate numbers. There is phenomenal shortage at every step. Ashas are overworked, auxiliary nurse midwives are overworked, nurses are overworked. Who is going to ask for this form? Who is going to get this form filled? And who is going to make data entry? And I don't think if Covaxin shots were associated with this, because Covaxin was given clearance in the continuation of phase 3. That is what the peculiarity was. Covishield was already approved for emergency authorization. There was no consent form asked. Nothing was asked for Covishield users or Covishield recipients. So if this was data which was being collected for Covaxin, soon after that, they also got this same emergency authorization that Covishield had in January. So if you are saying that these forms were collected, I would actually like to know how many forms were collected. Because even if you look at the whole state, whole country, I'm sure very few forms were collected. And because everybody has been trying to promote Covaxin at the cost of Covishield, and I think what I would call 19-20 between them, there is nothing very much to choose. But we as in the country, needs to promote indigenous vaccine for whatever nationalistic purposes. And that is why Covaxin information is coming out that with Covaxin, even the variants are getting, there is protection even from variants. Where are these data coming from except for very small scale results which are being conducted in the lab? Those cannot be really extrapolated, because even if you collect convalescent serum, say from 30 individuals, they themselves, as we were talking about in the context of plasma therapy, they themselves would have various levels of antibodies, and nobody is testing for T cell responses. So we have no idea what level of immunity, as one would call it, adaptive and immunity they would have, which will provide protection from reinfection. So everything is up in the air. Very poorly managed questionnaire or designed questionnaire. There is no systematic data collection. So what do you expect? I mean, there is nothing for me to say, even if there are data available, which will be in very minuscule numbers. I don't have an answer for your question because I haven't seen the data, but I wonder how much and how reliable the data are also.
So when experts like Dr. Anthony Fauci say that Covaxin is effective against the mutant.
If you read that Indian Express interview or some such interview where Dr. Tony Fauci talked, I have great regard for him. He led the United States in the very early battle quite reasonably well. He is knowledgeable, but his ignorance about Indian reality was so apparent in the interview. He started reading about Indian epidemic and Indian pandemic as he was supposed to talk to Indian Express. I'm sorry, I'm calling him names, but experts have their own place and they need to know where they stand. If you ask me the questions that you're asking either Gautam or Ramanan, I will have to accept that I'm not knowledgeable about it. And that should be the way ahead. I know my expertise, but I also know my limitations. So because Dr. Anthony Fauci has such a great status, he should not be commenting about India without knowing the reality. He says that make nationwide lockdown because you have increasing cases, and then in 1 month all the infrastructure, medical infrastructure will be put up. Are we joking? We have been struggling to put up that infrastructure for last 1 year. We haven't managed it. So this is what I mean. He does not know the reality of Indian situation. And that is why quoting him or making reference to what he's saying and asking me to respond is not going to go anywhere, I'm afraid.
No, that was just a mention.
That's right. But all I'm saying, I'm not saying, I mean, he is a respected scientist, and I even otherwise I agree that he is very knowledgeable. So I'm not undermining his scientific caliber. It's just he talking about Indian situation is what I'm criticizing about.
Right. So the next part of my question was that, do we have any studies on the level of protection a vaccine offers versus the antibodies that we develop from a prior infection?
Theoretical. No, I only have theoretical answers. There are some stray reports, like there was a report on CSR employees, which was about 1,000 or quite a few numbers, which was done. So in that group, there was data collected after how much is the antibody after first vaccine shot. Some of the individuals were already exposed and so on. So that kind of stray data are available. Again, if you are looking at T cell responses, they are available even in minority of the cases. So as Indian picture, we cannot say anything, but we Indians as human beings are unlikely to be radically different from the individuals in the rest of the globe. So there are such small pockets of studies from all over the world, especially developed countries from the United States or Europe and England and China. I don't know because I can't read the abstracts and whatever they are in Chinese. But otherwise, English language published abstracts and papers do suggest that there are enough antibodies and there are enough T cells which are getting generated, and reinfection can still take place. And that is what I'm trying to say, that there should be a difference made between reinfection, meaning infection, and disease. Even vaccinated individuals will and can get infected, but as others were saying, practically no one of them is showing very severe disease. So there will be some local infection and replication of the virus, but it will be cut short. So the dose or the number of virus particles will be much lower in the vaccinated individuals, even if the infection is by a variant. So that is what we need to understand. So using general term as reinfection is setting the alarm bells ringing. But if you look at healthcare workers, doctors who are getting exposed, who are working in COVID wards and are getting exposed day and night, or nurses or whoever, those are getting exposed so heavily that chances of reinfection in them are much higher. But as Gautam was saying, do we really know whether it is the same virus? Is it a variant? And is it because of the variant that they are getting infection? We have no idea. So do remember to make a distinction between infection and illness caused by the infection. And what we need to worry about is illness caused by infection. And that is definitely protected to a very, very significant extent by the vaccination.
All right. Thank you. Thank you for that response. Dr. Ravi, a week back, you had said NIMHANS, which is a part of INSACOG, has no infrastructure to do cell culture studies, and that all COVID samples found with the B1617 variant are being sent to National Institute of Virology, Pune, for these studies. Now, these studies will tell us about the transmission rate and the reproduction rate. Have we got any results back from Pune yet?
No, not yet. I was also not misquoted saying there is no infrastructure for cell culture. We are one of the oldest labs. We have grown SARS-CoV-2, but it's not our business to do this work. We are a hospital-based diagnostic lab. We are overburdened with SARS-CoV and many other infections that are also serious. So, and we don't have the manpower to indulge in such kind of research. There are institutes exclusively for research. Let them do that. We have absolutely no problem. Okay? And it is one thing I want to tell in a very lighter way. First time around, Ramanan, Gautam, Vinita, and Ravi were hailed as heroes. Today, viruses, virologists, and public health people have been dumped in the dustbin because of a second surge. I think people think that growing virus and doing sequencing is as easy as doing a rapid antigen test by putting something into somebody's nose and giving a result in 15 minutes. Come on, this is the first time. It requires time. In 3 months, I think we did a great job of close to 20,000 sequences. It's easy to criticize. Ask Vinita how much it requires to do sequencing. We have been doing sequencing for the last 5 years, but that is not for an emergency public health use. That is for a research question. So it will take time. UK is sequencing more than 100,000 sequences a day. Let them do it. Let them enjoy it. We have to be very focused in what we do, and it has to be backed up, most importantly, with very credible data. Even if it is not representative of the whole group, even if it is less in terms of proportion, I would like to see credible data. So we do isolate virus. We have isolated viruses. We are doing our bit, but it's a small BSL-3 facility and you don't expect us to do it. So I think there are experiments going on both at CCMB, I think also at Faridabad and at NIV Pune. So we will get those results. But Suraksha, why is everybody interested in variant? Why not wearing masks? I know it's very important for a society to be doing academics. You know, human beings, I worked 35 years in a behavioral institute, and let me tell you this much. This is not the first virus that has taught me behaviors. The biggest lesson I learned is from HIV. Okay? I learned behavioral medicine through HIV. And SARS-CoV can't hold a candle to HIV in terms of behavioral change. So let me tell you that we want to find excuses. Can we sit back and say all of us failed, and some of us failed miserably by not using what is so easily available to protect ourselves? Do variants penetrate masks more than non-variants? I don't know. Maybe Ramanan and Gautam will have
No,
data.
no, no. I think I fully agree with you. I think we've used the variance as an excuse for the policy failure. You're absolutely right,
But
100%.
variants are important from one context, which Vinita and Gautam and Ramanan said. Is it escaping a vaccine? Yes, that's a very important question. So that you have to tinker your vaccine.
Yeah.
Otherwise, it's a costly academic exercise. Leave it to scientists to romanticize with it. Thank you.
All right, sir. Dr. Ramanan, even if we had the kind of data that we don't have yet about whether the variant is driving the surge, et cetera, there is still that missing epidemiological link, right? We need to do robust contact tracing to see how many people have been affected by people who have this variant and not. So in terms of interventions by the government on isolating such clusters and having more stringent clamp down measures, we still have that missing epidemiological link.
It is, and one of my regrets over the last year and, since last February, among many things, is that we have not used that period for significant research. The number of papers coming out of India is abysmal, considering the amount of data that we have, the amount of contact tracing that has happened in this country, which dwarfs any other country, and the capacity within the country for scientific research. All of this is not translated into understanding the epidemic either for ourselves or for future generations or for other people. Just completely lost. Take, for instance, I always seem to want to answer the previous person's question. So what you asked, Dr. Ravi, the thing we're most interested in is the other variants penetrating, people who've already had the vaccination. Why are we not collecting serum from those people who are dying despite having been vaccinated and had the variant? Had COVID. And those are great opportunities. That helps you address the question of what is different about those people compared to other people that, the virus managed to. We all know people who've had the vaccine and died, right? And we know it's a small number theoretically, but we don't have the data from the last month and a half or so. So I think we're all chatting here as if the system there permits that kind of research study. That's an important research study to do. But I will tell you, there's no scientist in the country who will get permission to do a research study of that kind. And these are important studies to do if we want to escape. Very early, Jeremy Farrar, who's the head of the Wellcome Trust, he said, science is the only escape from this pandemic. And we have not used science. We can't say science, we did Bharat Biotech's Covaxin. That was Bharat Biotech's victory, and full kudos to them. That was not the scientific community at large. And I think broadly, I know that's not exactly what you asked me, we've not leveraged science to the extent that it's available in this country and the capacity that exists in this country to have really pulled the country out. And that's really disappointing. Sorry, I'm not in a great mood right now because obviously someone very close to me just died. So, I'm actually quite upset that we're just in this situation, which is just ridiculous.
I'm sorry, my condolences, sir. I'm really sorry for your loss. Professor Menon, we are on the subject of death. What can be done apart from journalists counting pyres in cremation grounds and obituaries in newspapers and the number of spots that have been taken in graveyards? Apart from that, what else can we do to correctly estimate the number of deaths in this country due to COVID-19? Now, the National Center for Disease Informatics, they tried to introduce this MCCD system where the medical cause of death can be correctly recorded, but that is not happening. That didn't take off. So what can be done to correctly estimate the deaths in India?
That's a hard question and sort of hard to do. First of all, these things are always done very much later. When you sort of look back, they're just much easier to do that way rather than when you're right inside a pandemic, when you know that there are serious problems with the counting, but it's hard to adjust for it. Certainly everything that you mentioned, the obituaries, the people, journalists actually standing in front of crematoria and burial grounds to figure out what is the discrepancy between official numbers and the real numbers, that these sort of drones over crematoria to try and find out how many bodies are there at a particular point. These are all sort of somewhat more high-tech ways to do it. I suspect that it will be very hard to do. If at all you get a better idea, it will only be much late for the reasons that you mentioned. We don't do a good job of counting deaths under normal circumstances. Most Indians still die at home. About 80% of deaths are registered, but only 20% of that 80% has some medically certified cause of death. You do little better in the main cities, you do pretty badly in the remote districts. So that's where I think you will miss a lot of the numbers. The further away you get from the cities, from what we're hearing from, for example, rural UP or rural MP, etc., there's a vast numbers there that are just not being reported, people not being tested, whole villages that seem to be afflicted with coughs and fevers, but they don't know where to get tested. The nearest test center, RT-PCR, is something like 80 kilometers away. And so deaths there may not be recorded at all as COVID deaths in the first place. So what exactly is this huge background of deaths that will never be recorded? How will we ever know? Maybe you have to go back, some historian, some later time will have to go back and ask people, how many family members did you lose here, sort of do a statistical survey across India. And then we might get a better idea. But this is really linked to the problem that under normal circumstances, we don't do a good job of this. And that, in fact, is a general statement about many things. Under normal circumstances, we don't do the sort of things that would have enabled us to understand data better. So that, I think, is a priority.
Right. Dr. Ramanan, we have a population that is only comparable to China's, and China did a really good job of containing the virus transmission. Apart from that, European nations have seen multiple waves. The United States has vaccinated 1/3 of its population and seems to have not lost the plot like India did. So what are the lessons that we can learn from other countries while we ride this second wave?
Again, like I said, there's not much we can do at this point. This is, we just have to just go along. It's not, there is nothing literally that can be done in the middle of this time. I know it sounds like, we're just all in response mode. We're trying to organize oxygen. We can't build any system in the middle of this. Sequencing more is not going to get us out of this wave. Testing more is not necessarily going to get us out of this wave. It's simple mask wearing that's going to get us out of this wave. And people will mask because they're seeing the case numbers. But I hope that the one lesson that we should learn, and which is a mistake that has been made in every country that do a really job dealing with an epidemic, is that hiding numbers and denying an epidemic is the best way to make it go on for much longer. You can look at the example of South Africa with HIV and the example of Thailand and Uganda with HIV. Thailand and Uganda were open about it. They put their case numbers out. They explained to people why the virus is transmitted, and they controlled it really well. In fact, India did very well with HIV, as a matter of fact, for the same reason. India had a very proactive program of testing, identifying high-risk contacts, and that's why we got on top of HIV when India was predicted to have the worst HIV epidemic in the world. And we've not done that for this one. And the country that didn't do it the last time around for HIV was South Africa. They denied it. They denied there was such a thing, and all the countries that denied it and held their data back and didn't let the public respond basically ended up doing much worse. And I think the lesson for us is controlling data prevents people from responding rationally to epidemics. And people's rational response to disease is what brings the disease under control. It's as simple as that.
One last question before we open the floor for audience questions. Any of you can answer this question. Is the data not being available about AEFIs in the country, be it deaths or severe reactions to the vaccine, a cause for concern in India? Because in every health ministry briefing, we've been told that it is a minuscule percent of the population that has suffered an AEFI.
I can possibly talk about it if you're okay about it. So what we have been saying, that there is very, very inadequate manpower to do the work that is falling on us meaning medical fraternity in a sense, that is also contributing to very, very, very pathetic reporting of the AEFIs. Because if you see in the initial period when healthcare workers were getting vaccinated, there was reasonable reporting in terms of numbers, in terms of diversity of responses, and so on. But those were healthcare workers, so they were specifically asked, or also they were probably a little more aware that this can be done and should be done. But thereafter, as the vaccination rates increased, so that there was no follow-up, nobody who takes a vaccine has been told to go on CoWIN app and register your side effects. even if they are fever and local pain and so on. So if there is no message being conveyed, nobody is going to do it. So only serious and severe adverse events are the ones which, if at all, will get reported. And from what I've been hearing from the ground is that people who are doing vaccinations day long, they have given some 300 vaccines. At the end of that, those records have to be made. And also, if somebody has an adverse event, they are the ones who are supposed to do the uploading, as in data entry. So this is simply beyond them. They are either faking or not doing it. So the major drop in reporting is not because there are no side effects. It is because we haven't publicized that there is a need to understand this, so that we will know whether this clotting, bleeding kind of very, very rare side effect that has been identified with Covishield meaning Oxford vaccine, AstraZeneca vaccine, whether that is actually happening in India or many other things. But the numbers are really, really poor. And it is easy to blame the medical field again for this, but one has to accept the reality. If we are trying to recruit third MBBS students as full-fledged doctors for treatment, you can imagine in every other field there is shortage of people, and that shortage of people is also contributing to lack of data. And hence we cannot make policy, or we cannot estimate how different or how similar we as population are from the rest of the world, where they are having much better reporting system. So AEFI has become a real black box, and the problem is with not reporting.
Right. Thank you, ma'am. Thank you for the response. So I will I will read out the audience questions now. We've got quite a lot. The first one coming from Bharatish Devendra Basti. His question is it really necessary to increase the testing in a country with limited health expenditure, especially when the areas has outblown positivity just for statistics? Syndromic management may be enough. The same budget can be used for fruitful management. Do any of you want to take this question?
At this stage, I would sort of agree with that. Sorry, I can take that. I think now the numbers are just so large that if anyone shows the slightest symptoms of COVID-19, all they should do is isolate themselves, stay away from their family members, and keep track of their health as far as possible and not overload. If you don't have to go to hospital, don't go to hospital. So I would not even say that that person needs to be tested. If you show symptoms of COVID-19 in a situation of such huge community prevalence, that's probably the best thing to do, and you should be treated syndromically. But I mean, as someone who thinks about epidemiology, that's one would like to have a track of where the numbers are. Are they large here, small there? How is it spreading? How is it increasing? But in a situation like this, I agree that it probably doesn't make sense to do the sort of testing that you might want to do, unless you have cheaper alternatives. For example, the rat test that you can go very quickly, get tested, have done at home, have much more cheaply available, then that could become an alternative. But the more of a burden you impose on someone, to get somebody to come home, test it, tell you that results 6 days later, etc., and pay money for it, the more difficult it is, and people will not do it.
Dr. Ramanan, from an epidemiological point of view, is it okay if we abandon testing and just isolate ourselves if we have symptoms?
No, I think it's important to test, because many people, they may come in contact, and remember, we're not all in places with high levels of epidemic. So some places are with lower levels of epidemic, and so sometimes people only when they get tested, because they may get tested because they knew they came in contact. I'll give you an example. A friend of mine, he'd happened to come in contact with someone who then told him, I've been tested COVID positive. Now, this friend of mine actually then went and got tested. He had no symptoms, and he discovered he was COVID positive, and then went and isolated himself. He would not have done that but for the test, right? So I think testing is still very important. And as a fraction of budget, you have to remember the amount of GDP India is losing every day to COVID is enormous. Let us stop this penny pinching and spend the money that it takes to get out of this pandemic. And the cost of COVID testing is so microscopic, there is no great health investment you'll make by saving this money on testing. And I think that's where we fall short. We don't realize that investing in health and infrastructure, which includes testing, all of this is what keeps developed countries ahead, and we just don't make those investments. So let's not nickel and dime on these small things. Just do the testing as widely as possible. In fact, I would go the opposite. I would just make testing free for everybody in the country. It's just worth it, so that people will come and get tested, and then they can isolate themselves And this friend of mine, isolated himself, and thanks to that, his family didn't get COVID. But if testing was not being done, then he had no way of knowing if his contact with someone who was COVID positive actually protected him or not. But I also, I again, we get some idea of the trends also from this kind of testing data at a gross public health level as well. And all of these are important. Remember what we come back to. You have to give information to people to do the right thing. Testing information is one of those. Telling them the prevalence is another one of those. So as much information you can feed back to people, I think people will self-protect for the simple reason that nobody wants to have COVID and either give it to their family members. You're now hearing about so many people who have so much guilt because they had COVID, they gave it to their parents, and their parents died. Now, who wants to live with that kind of guilt?
Right. So another question we have is clearly our children have been out of schools for more than a year now. So this question is pertaining to the status of vaccine trials in children and adolescents in India. What is the status is the question, and Canada, US, UK are clearing the vaccines for adolescents. So does anybody want to answer what is the status of vaccine trials in children?
I'll take that.
Yes.
None of the vaccines that have been approved for emergency use are under trials in India in adolescents. But there is another indigenous vaccine, which is a DNA vaccine, the Zydus Cadila vaccine, which is now under trials, and they have got permissions to include children or adolescents between 9 and 18. That data is expected sometime in the next 4 to 6 weeks. So, but that's a DNA vaccine. The only issue with that vaccine is it is 3 doses. It is not 2 doses. It's a complicated. Of course, we'll have to wait for the vaccine trial results to know how much it is effective. But there is an age group of 9 to 18 included in that particular trial.
Okay. I think somebody from Karnataka, a 16-year-old girl, was vaccinated with Zydus Cadila in the vaccine trials, if I'm not wrong. Is that right, Dr. Ravi?
Yes.
Okay. Another question we have is it advisable to wear a mask during a morning walk or a jog? There are also rumors that the virus exists in the air and therefore people should stop going for a morning walk or a jog. Is that true? Do any of you want to take it?
I don't mind sticking my neck out. This thing about virus in the air has been blown out of proportion. Out of context, it has been put. Indoors, yes, it lingers in air. Outdoors, it gets pushed away by the raft of the wind. Would you want to wear a mask when you walk or jog? Yes. If there are 1,000 people walking on the road and jogging with you, yes, I would wear a mask. If I go for walk at 5:30 the way I do wear a mask, but I have the luxury of bringing it down and taking a fresh breath of oxygen.
Yeah.
I think one thing COVID has taught me is life is not black and white. Life we live in gray. There is always a middle path to everything. If you take testing, should we stop testing? Should we increase testing? No. As everybody is here is telling, let the message go. Testing is very important. It's very, very important in the context which Ramanan said, and I'll go one point beyond what he said. If you don't test asymptomatic contacts and don't let them know they are positive, they don't know they are positive. And they will deteriorate in the second week. People deteriorate in the second week, they gasp and start looking for oxygen in the bed. I'm sorry, it's too late. Nobody can do it. So for me as an individual, if I know I am a contact of a COVID patient, it's my responsibility to go and get tested. I think these kind of messages which Ramanan said is very important. Then people will take it seriously.
Yeah. So Suraksha, on that note, I also want to address it. The only time I get a walk is for 30 minutes, which is right now, and we're supposed to close at 6. I have to come back to take calls. So I am going out for a walk, and as Dr. Ravi said, because there's no one else around, I will have my mask on, but I will I won't be so stringent on it if I'm walking a little fast and I need to breathe a little more. But I'll have to drop off now, unfortunately, because I have to come back in 20 minutes for half an hour phone calls.
No problem, sir. Thank you so much for joining.
Thank you so much. Thank you all for having me.
Bye.
Right.
So another question we have from Sunil Shankar is, this is something along the lines of what was asked previously. Is the present virus airborne? What is the extent it travels up to? That's the question.
It's completely airborne. There's no doubt about it. It's transmitted through small aerosols. They stay in the air for a certain while. There was this big discussion about whether these were bigger droplets that fell to the ground early, or you had to worry about surfaces. It's pretty clear now that it's completely respiratory. It can stay in the air for several hours, which is why masking is very crucial. And just to come back to another point about this outside mask wearing, I think it's very important to understand the role of ventilation and to understand that the problem with small enclosed spaces that are badly ventilated is that they're the worst possible situation that you could possibly be in. Outside, fine, not too many people around, wear a mask, don't wear a mask, probably not much of a difference because the droplets are taken away very fast by the typically turbulent airflows. But inside is where you really have to watch. Any small, badly ventilated space, whether a theater, whether a mall, whether a shop, etc., at home, that's where you have to be really careful. I think you can be a little more relaxed outside, although at this time, with such a high number of people who have COVID-19 in the community, even there, I would urge mask wearing and caution.
We have a follow-up question from Priya Mandre, who asks, if I test positive all of a sudden, should I go to a hospital first or make myself isolated at house itself?
Well, in a way, this is a simple question. I hope I'm audible now. I was getting messages that I'm not audible. Okay. So yes, if you're living completely on your own in a single, in a house of your own with nobody coming and going, you don't need to isolate. You are isolated, but then don't step out of the house. But isolation is essential because this virus, as we are saying, gets transmitted via air to everybody and anybody around us, and ill-ventilated, closed rooms, and many more people around. All of these are invitations for transmission between people. And asymptomatic is not necessarily meaning that you are not transmitting it. You just don't have symptoms. You have enough RT-PCR test or rapid antigen test, whichever one was done to diagnose, that has come positive, which means you are capable of spreading the virus. Hence, the precautions and isolation is absolutely necessary. The durations have been changing, but those let us not talk. But if it remains completely asymptomatic from the day of diagnosis, 10 days later, if you remain asymptomatic, of course you are normally on a statistical level, you are free to go out. But if anybody gets a CT value at the time of RT-PCR diagnosis, then sometimes the lower the CT value, which means higher the viral load. So asymptomatics can also rarely have low CT values, which means very high load. So they are better off testing again to see that they are actually RT-PCR negative. But yes, isolation is essential.
Thank you, ma'am. Another question we have from Hemachandra Basappa. I am 70 years old. After 8 weeks after getting the first jab, I have not been able to get a slot with the vaccine for the second jab. What happens now?
Ravi, you can respond. Yeah.
Yeah, I really feel sorry. That is the state of affairs for most people who are waiting for the second jab now. Especially the last 3 weeks, there's been very acute shortage. I think that is because the demand has gone up. We have opened it for all ages, and ramping up of production is happening. So I can only say that hopefully in the next 3-4 weeks, this gentleman will get his vaccine. If it is Covishield, you're okay. Only thing is, don't run around looking for vaccine and get infected. Stay at home till you get one, because the chances of getting infected looking for vaccine in 10 centers is going to be very, very high.
Thank you, sir. This is from Mr. Srinivas G. What is the duration of vaccine protection period and the importance of booster dose, its duration, so on and so forth?
So if I may, right now, because the vaccine trial, this is a new disease that we had said earlier in the show. So we don't know enough about it. We know a lot more now than say last January or last February. But even then, the information that we have about biology, infection, all sorts of things is still limited. And the same applies even for lasting of immune response. So post-infection or post-vaccination, for how long the protection provided by either vaccination or infection would last is still an unanswered question. It is work in progress. So if you will remember that the early phases of clinical trial for some of the mRNA vaccines started last April, May, or thereabouts. So we have now about 10-month period over which those early recruits have been observed, and most of them are protected. So as a general statement, one can say at least with mRNA vaccines, we know that the immunity lasts for about 10 months and it is protective. About other vaccines, as the time goes by, we will keep revising this figure. And at some point, it may happen that for some vaccines, the period may end, say, at 1 year or 1.5 years, and some others, it may continue for 2 years, 2.5 years. Right now, there is no prediction to be made, but all vaccines that we are taking are safe for sure. They are providing protection for sure. So for overcoming the current wave, this second wave, third wave, whatever, if we are adequately immunized, we are likely to get very reasonable protection in the next 6-8 months to a year. So that should be reassuring, and that is what should encourage everyone to go and get a vaccine shot. Unfortunately, the vaccine shots are not available, as we just talked about for the previous question. That's the problem.
Right. Thank you, ma'am. So this question is in the context of a lot of RT-PCR tests not picking up the COVID-19 infection. While the CT scan shows there's an infection, the RT-PCR test shows negative. So please throw light on false positive and false negative results in RT-PCR tests.
Okay, I'll go for it. There's a lot of discussion on this, and it's most welcome, because more discussion we have, I guess more people will get the correct information. There's no test in human history that is 100% sensitive and 100% specific. A. B. RT-PCR for SARS-CoV-2 infection is the gold standard because it's most practical and it has a sensitivity of 90 to 95% at a specific window. And what is this window? 5 to 7 days after a person manifests, comes in contact with a positive person, or as soon as somebody is symptomatic, the test is sensitive. Remember, before the 5th day and after the 7th day, the 90% sensitivity does not hold. Now, this is as the problem with the test, I'm telling. But the problem with testing is different from problem with a test. The pre-testing processes, if they are compromised, they contribute hugely to false results. That is specimen collection. When you have a surge like this, if I am a swab collector, believe me, if I'm given a target of 200 swab collections, 20, I would not have even put it fully into the nose or the throat. So the way the specimen is collected, the way it is transported, the way it is stored in labs for 48 hours, there is no fridge space. You put it in cool boxes, leave it outside, then you do a test. So there are many variables before the test is done. And the people come, as I told you earlier, worsening of symptoms and all complications start between day 5 or day 6 and last till day 12. If I have not been tested and I come gasping, or I come with a ground glass appearance in CT scan and my nose is swabbed, you will not get virus. You will not get RNA. But you take my bowel fluid, your chances of detecting is much more than the nose or the throat. So there is a context for everything.
Ravi, extend the bowel. I mean, full form.
Sorry, Vinita, I should do that. bronchoalveolar lavar fluid, in lay language, lung fluid. You have to collect lung fluid. So that is where pundits are telling, no, CT scan is better than PCR. And of course, the biggest hilarious, amusing explanation I've heard is that mutants are not picked up by RT-PCR. The current RT-PCRs that's being used in the country are some of the best because we detect multiple genes, right? And mutants are missed if you rely only on spike protein. Thank God mutants are not mutating in so many other genes that we are missing them in RT-PCR. I hope these are some of the points that I've kept it.
Yes. Thank you, sir. Mr. Amarendra Krishna would like to ask, hello everyone, to confirm whether I'm COVID positive, which test should I go through? RT-PCR or antigen or CT scan or C-reactive proteins? For an accurate COVID positive result, which test should I go through?
RT-PCR, if you are in the first week after contact with the patient or you're symptomatic. RT-PCR of lung fluids if you are in the second week and if you have severe infection. RAT test is useful in symptomatics in the current situation when there is a surge, but RAT negatives have to be subjected to RT-PCR, but their predictive value in symptomatics during such a surge is very, very high. It's about 70-75%, and they give you results fast. They have an advantage. And CT scan is required to assess whether somebody has to be put on certain kind of drugs. It is very useful. And when oxygen levels are low, to find out how much of the lung is occupied by fluid. So it is a very useful test to decide on treatment options, not necessarily for diagnosis. And all the other tests, whether it is blood tests, are helpful in deciding on which drug to give, whether it is IL-6, whether it is ferritin, whether it is D-dimer, whether it's C-reactive protein. They all are tests used for management by a clinician.
Right. Thank you for that, sir. We have a viewer on YouTube, Ravi Kumar BN, who's asking, are these vaccines effective against a mutated COVID-19 virus? I think we answered this in the earlier part of our discussion, but again, just as a general statement, are they effective?
As far as we know, yes.
They are. And one of our editorial members, the Deccan Herald, would like to know what each of our panelists have been vaccinated with, as in which brand. And they'd like to know from you if Covaxin is better, Covishield is better, or if she should wait for Pfizer to come to India.
Waiting for vaccines that show promise is foolish, in my opinion. I would not wait. All vaccines, as I said, are giving protection against serious disease and death. If you are looking for protection against infection, God help you. Such a vaccine is not on the horizon. Which vaccine to choose? Take whatever is available. That's the situation currently.
She would like to know what each of our panelists have been vaccinated with.
I don't think we are in a classy restaurant where there is a la carte menu in front of you and you can order mushroom soup and some other starters. We are not, unfortunately, in that situation.
Right, sir. So just to answer her question, she'd like to know what you have been vaccinated with.
I took what was given to me, Covishield.
All right, Dr. Pal.
The frame is stuck, I think. I can go ahead.
Yeah,
I took Covishield.
Okay.
And again, I agree completely. Whichever vaccine you can get, take it. It doesn't matter. You don't have to worry about choosing.
Right. Sunil Shankar would like to know about fomite. Yeah, go on, sir. What is that?
Vinita's screen is frozen.
Yeah.
Yes. Dr. Bal, we're waiting for you to come back. Okay. Sunil Shankar would like to know about fomite transmission of the SARS-CoV-2 virus.
So for my transmission, it's transmission of the virus through, sorry, Dr. I just
No,
go ahead
please
and
go ahead. Please go ahead.
through surfaces, through intermediate things that you might touch where someone has left a bit of virus residue on it. Now we believe it's less and less important. Earlier in the beginning, in the earlier first few months of when SARS-CoV-2 came, when COVID-19 came, we thought that it was more important. Now we really believe that the primary route, and probably the most important route, is really just droplets, small droplets. So I would be less worried about this relentless cleaning of surfaces, etc., etc. I would still do it as a matter of care, but I would worry much more about ventilation and masking.
Right. So Mr. Sunil Shankar would like to ask his question directly to both of you. Mr. Sunil Shankar, please go ahead.
Yeah, hi. Good evening, gentlemen, and it's a privilege to talk to the Salite panel, and much accolades to Deccan Herald for organizing such a seminar in such testing times. Sir, there has been a lot of talk and discourse on the corrective measures like testing and other things. And Dr. Ravi probably would help me in this situation. I've just lost my sister a few days back to a COVID situation caused initially because of an allergy, we thought, because of construction activity around our residences today. Why isn't the government not taking preventive measures like the causes for spread? Of course, like you said, the main way would be probably through, airborne aerosols, but pollution as such with respect to new construction work, like breaking of buildings and of course the foundation work, carries the virus too. And I've probably tried to read a few articles on the Google website. I hope that government construction activity can be stalled, and if you can share some light on that, sir, and if you can also probably help us out in this situation, it would be like even a single life saved has its value in gold or whatever I'm not able to articulate well on that. So.
Thank you, Sunil, and please accept my condolences. I'm sorry you're going through difficult times. The straight answer to your question is there cannot be half-hearted attempts to do something. That is what I would say. Having said that, my answer to your question would be the difference between first wave and second wave. I think it's time to audit. The first wave, the difference I found was interventions were data-driven. Technical experts' advice was taken very seriously. There was very little gap between what was advised and what was implemented. I'm sorry, this time around, that did not happen. That's one of the concerns I have, that any intervention that we suggest should be data-driven. Even in this case, the advice given by experts was don't do half-hearted things. When you close down, you close down. It is neither a lockdown nor is it a partial curfew. I think from what I am hearing, from Monday it's going to be a total lockdown. And I hope a total lockdown is a real total lockdown where all activities are stopped. Last time, the entire nation debated about lives. This time, suddenly livelihoods came into the picture. I hope the third wave, if it comes, we balance both lives and livelihoods properly. I think it's very, very important. I'm very fond of saying this, that the road ahead is full of road humps. You cannot drive on this with the same speed on a road hump. You have to respect, slow down, get over the hump, accelerate, again slow down, again the road ahead is bumpy, and we have to learn to navigate it together. I agree with you. Any activity will contribute definitely to spread.
Mr. Sunil, I hope that answers your question. Moving on, Ms. Indrani Karuna Sagar asks, I believe that too much of public information on medication is resulting in self-medication with a depressing effect on the individual's body response. All those who can afford to take hydroxychloroquine, remdesivir, dexamethasone, etc., are doing so, and all this is resulting in suppressing the natural immune response in most cases. Medication should be compulsorily under doctor's supervision. Stay home, hydrate yourself, only manage the temperature rise. Regular gargling or steam inhalation would be the best adage. I think she asked a question with a comment at the end. So her question is about self-medication.
I can't agree more with my dear friend Dr. Indrani Karunasagar. But then look at as I think both Gautam and Ramanan said, we live in a society where systems are not in place, and we are now trying to put systems in place during the height of a pandemic. This country has on paper a rule saying that drugs have to be only given on prescription. But we all know you can get anything over the pharmacy counter. Whatever you want, you will get it. And yes, too much of information results in people experimenting on themselves. I hope one big gap I see in this time around, and I am also at a loss how to address it, is we are not giving information in a way that people can change their behavior. Behavior change communication is an entirely different ballgame. Fear does not change. Panic, inducing panic does not change behavior. I know from my experience, threat will not change behavior. What you need to do is communicate facts straight and give alternatives. There is another way of doing it. The other way of doing it is you can go out, do whatever you want, but mask and try to avoid crowds. How does crowding help economic activity? I want to know. I'm asking people, why only crowding promotes economy, livelihoods? Somewhere we are not communicating this to people. And that I think is the biggest challenge for us. If we have to manage future waves, I think we have to focus on behavior change. Whatever other things we do, sequencing, whatever you do, you collect data and you want to give as many jabs as you want. Even after jabs, virus will be circulating. Who told you virus will not be circulating? So I think we have a collective responsibility, both media and all of us experts, to communicate in a way that people change their behavior.
So we'll take one last question and then final comments from both of you on navigating the second wave and the lessons that we can learn from it. The last question here is from Sutirto Roy on Facebook. Is there an estimated date on when the vaccine shortage for ages 18 to 44 may be resolved? I think this is a question for the government, but go ahead.
I think it will take at least a few months, would be my guess, given current levels of shortage. It's, I think, right to prioritize people who are most at risk. That's the 45 plus, comorbidity, 60 plus, etc. That's where you will see the real effect on mortality. And when with younger people, one may hope, if you sort of assume that there's some effect on transmission, that there might be some. But right now, I would say prioritize the 45 plus coexisting, comorbidities plus the 60 plus population. That's important. I don't see it's easing for at least another month and a half, but maybe Dr. Ravi has a different view.
Much longer, Gautam, much longer.
Right.
I don't see it easing in the next 4 months. Vinita has joined because I know the capacities of these industries, and I know we are also trying to get more vaccines on board, but we are a huge country. We are a huge country, and the requirement, even if you put a simple math and arithmetic and take all the doses available in the entire globe, and you want to give vaccine to India, no other country, even then we won't complete vaccinating 80% in 6 months. So let's not kid ourselves. Vaccination is important. I'm not against vaccination, but using vaccination as an excuse and continuing irresponsible behavior is not going to take us anywhere. We do have a problem.
So I'd like to invite closing remarks from all of you on how we can navigate the second wave and what are the lessons that we can learn from this wave. Professor Menon.
I really liked what Dr. Ravi said about responsibility, in a sense, and how that should shape social behavior going forward. One thing that we've done with communication is that we've always said, do not do this, do not do that, do not do something else. We should shift to saying, you can do this because this is safe, provided you do the following. stay outside. Inside inside, bad ventilation is always bad. Outside, wearing masks, not too crowded, good. That is something that you can do. In the short term, until we get over this hill of the current wave, maybe it's best to even reduce that a little bit. But in the longer term, I don't see why that shouldn't be a positive message that we should be communicating. We don't know what's going to happen in the future, but if we put the right seeds of social behavior in that's appropriate, we can cope with anything that might happen in the future because we've got our principles right.
Thank you, sir. Dr. Ravi, what are our lessons from this wave?
Okay, my lessons are that I think we should have a number of small technical groups that want the government when the 7-day moving average is increasing, and we may have to have many lockdowns. Whatever we created now, it will be sad if it is not sustained. Our people in the country deserve oxygenated beds, they deserve ICUs, and we need to sustain it. And we need to see that oxygen availability will be there for the next 1 year. Because our primary objective is to save lives. It's very difficult to cut transmissions. Only we have to appeal to people to change their behavior. And secondly, I think we know who are the people who are going to get infected and who are at risk for the third wave. Right now, we start preparing. We will probably mitigate a lot of misery for the third wave. And I would reiterate that intervention should be data driven. Experts' advice should be taken seriously. All congregations, I'm a very radical in my thinking. No elections, no religious functions. Let us go through another year safely doing what is minimally required. And I would even say children can go on for online education. I don't know how much psychological impact it will have, but maybe 1 month school, then no school. I don't know. I think this is the time we should be having those debates and come up with what is agreeable to everybody, that they will say, yes, we will all follow this minimal set of rules. I think it's a great opportunity. Every calamity gives an opportunity. I look at it because I'm an optimist.
Thank you so much, Dr. Ravi. Thank you, Professor Gautam Menon, for joining us. We are sad that Dr. Bal and Dr. Ramanan had to leave the discussion much earlier, but thanks to both of them too. I hope our viewers had some benefit from listening to our experts and their insights. Log on to DeccanHerald.com for all the news. Follow us at Deccan Herald on Facebook, Twitter, Instagram, and YouTube for all the updates. Download the DH app for the latest news. Take care, stay safe, and please get vaccinated. Thank you.
Thank you, Suraksha. Bye, Gautam.
See you. Take care.